Well, hello, everybody. This is Allie Orwig with the Indiana Rural Health Association. We have with us Kate Hill, who is the VP of Clinical Services with the compliance team. She's going to talk to us a little bit about the regulations coming up for emergency preparedness in all of the clinics. If you do have any questions, we will provide our contact information at the end of today's presentation. You can certainly contact Kate or myself at any time. We also will have the slides available by request. So without further ado, I will go ahead and turn it over to you, Kate.
Thank you, Allie, and welcome everyone. We are delighted to be presenting here today. What we're finding is this regulation is in effect as of November 15th, 2017. So should you be surveyed at any date thereafter, you're expected to have all this work completed. And I will say it's a fair amount. So I hope, given that it's already July 20th, that you have begun. So let's get it started.
Some lessons we've learned. 2005, we learned from Hurricane Katrina. At that point on the storm, entire lifetimes of healthcare documentation were lost forever for many critically and chronically ill patients. And of course, as you know, EMR is now the standard. In 2013, an EF5 tornado at Moore Medical Center, Oklahoma, where approximately 50 patients, staff, 300 community members survived that. But that caused major displacement for staff, patients, and it took 4 years to rebuild. In 2015, Inland Regional Center in California, 14 people were killed and 22 injured in a shooting. We now teach healthcare staff to run, hide, fight when immediate threat is noted. All these things we learned, including the big one in 2017 in UK, who slashed their budget for IT updates. Their security was not acceptable, and they had a major nightmare in trying to perform their duties with the computers down and in someone else's control, actually. And that's a major issue. So because of that and a number of things, proposed by CMS in 2013, a new regulation which would provide consistent emergency preparedness requirements, enhance patient safety during emergencies for persons served by Medicare and Medicaid purchasing facilities, and establish a more coordinated and defined response to natural and man-made disasters. The EP requirements, and I'll refer to them as EP so I don't have to say emergency preparedness for the hour, requirements for Medicare and Medicaid participating providers were published in September of 2016, applies to all 17 provider supplier types, and RHCs and FQHCs are specifically named, and its compliance required for participation in Medicare. The implementation date is November 15th, 2017, which, as I said, is rapidly approaching. So I'm going to include in this presentation the interpretive guidelines. Those are sub-regulatory guidelines, so they are not law. They do come from CMS, and they are recommendations for the surveyors in the states, as well as accreditation organizations like the compliance team. And they establish expectations for the function states perform in enforcing the regulatory requirements. So you do not require, facilities don't need the interpretive guidelines in order to implement the regulatory requirements, but we do have them. So I've put them all in here for you. This rule is accompanied by extensive resources that providers and suppliers can use to establish their emergency preparedness programs. So all those things we learned in the first couple slides is what we're trying to find ways to deal with those should they happen in our neighborhood. We hope none of them do, but life doesn't always go that way. So 491.12 is where we find our emergency preparedness for rural health clinics. And if you are wanting to read that rule specifically, exactly as the government wrote it, it's at 42 CFR 491.12, and you would Google that and it would come right up. Always make sure when you do that that you are looking at the electronic version of the CFR, because they don't update the paper one. It has to be on the electronic. And there's usually a choice, a click on at the top. So the RHC and/or federally qualified health center must comply with all applicable federal, state, and local emergency preparedness requirements. The RHC must establish and maintain an emergency preparedness program that meets the requirements of this section. The emergency preparedness program must include, but not be limited to, the following 4 elements: risk assessment and planning, procedures and policies, communication plan, and training and testing. So that's how we've divided this for this presentation today. So the rural health clinic, just read that. I don't need to read that again. Sorry about that. So the first is the emergency plan. The RHC, and I'll leave FQHC because I don't believe there are any on the call, but you see it if you are one, okay? Must develop and maintain an emergency preparedness plan that must be reviewed and updated at least annually. You will hear that about 20 times, as the government put it in the paper 20 times. So they do want you to review and update annually. The plan must do all the following. Number one, be based on and include a documented, facility-based, community-based risk assessment utilizing an all-hazards approach. Include strategies for addressing emergency events identified by the risk assessment, and address your patient population, including but not limited to the type of services you offer or have the ability to provide in an emergency, and continuity of operations, including delegations of authority and succession plans. So we'll explain a little bit more about that as we go. It must include a process for cooperation and collaboration with local, tribal, regional, state, and federal emergency preparedness officials' efforts to maintain an integrated response during a disaster or emergency situation, including documentation of the RHC's efforts to contact such officials when applicable, and of its participation in collaborative and cooperative planning efforts. So it's telling you, even if you didn't do something, you must document that you tried to communicate with somebody at the federal level or FEMA or somewhere. So that's a very important piece to this, in that they're going to ask to see that documentation when they come to survey you. The interpretive guidelines then for that first part say, an RHC's emergency preparedness program must describe the RHC's comprehensive approach to meet health, safety, and security needs of their staff and patient population during an emergency or disaster situation, and address how the RHC would coordinate with other healthcare facilities, as well as the whole community during an emergency or disaster. It doesn't matter if it's natural, a storm, a tornado, or man-made, a terrorist attack, either way. The emergency preparedness program must comply with all applicable federal, state, and local emergency preparedness requirements, which means you need to know what Indiana's laws are on that. What do they say at your emergency preparedness department in Indiana? But now, they're going to tell us here what they've directed, what CMS has directed the state surveyors and us as well to look for when we come to survey you after November 15th. Number one, we're to interview their leadership and ask him or her or them to describe the RHC's emergency preparedness program. So first thing, your manager is going to tell us what your program is. Ask the leadership to identify the hazards that were identified. And I will caution you here, we don't want to just say tornado and power outage. We don't want to just say flooding. We want to include a real detailed description that we have looked into our community, and we know that that freight train that rolls through here every night at 9 p.m. carries chemicals, or may carry chemicals, or perhaps even worse things. There's ammo dumped around, all kinds of things. What rolls through our town that could cause this problem? So you must, and that's what's known as the all hazards approach. And then, of course, the random shooter who very well may walk into a clinic, and how do you manage that? So from soup to nuts, kind of an all hazards approach. 3, interview the leadership and ask them to describe the following: the RHC's patient population that would be at risk during emergency, the services the RHC would be able to provide during the emergency, how it continues to provide the operations during emergency, and the delegation of authority. So say your clinic manager was perhaps injured or worse in some kind of an emergency. Who's stepping up? Who's next? And you need to identify this person by title. Doesn't have to be the name, but by title. Number 4, they're instructed to ask to see the facility's written emergency preparedness program policies and procedures, and verify that you have a plan by asking to see a copy of the plan. That's redundant, isn't it? I typed this exactly as the government put it out. So. Number 5, review the plan to verify its contents. It contains, the following required elements: a documented clinic-based, community-based risk assessment, strategies for addressing emergency events identified by the risk assessment, and address the patient population, but not limited to the types of services the clinic provides in an emergency, including delegations. I feel like I just read that to you. Number 5, a process of cooperation and collaboration with local, tribal, regional, state, and federal emergency preparedness officials. Efforts to maintain an integrated response during a disaster. So where do you fit into that formula with the hospital, with the state, with the federal agency? Including documentation of your efforts, again, to contact these officials, and when applicable, of its participation in collaborative and cooperative planning efforts. Ensure the word comprehensive in the RHC's emergency preparedness program considers a multitude of events, and I've covered that already. And number 7, verify the plan is reviewed and annually updated, which we get. Now, policies and procedures. The RHC must develop and implement emergency preparedness policies based on the emergency plan set forth in paragraph A of the section, risk assessment, paragraph A1, and communication, paragraph C. The policies and procedures must be reviewed and updated annually. At a minimum, the policy and procedures must address the following: the safe evacuation from the clinic, which includes appropriate placement of exit signs, staff responsibilities, and needs of the patients. So you're going to have lighted exit signs because we need to see those in the dark or in the smoke. We're going to have staff responsibilities outlined. Those people very well may be interviewed. If you wrote LPN, MA, RN has this responsibility, they're going to be interviewed and asked to tell the surveyor what their responsibility is in an emergency. And so you're going to do that training, which comes up later, to teach them that so they understand and they can accomplish the goal. And of course, the needs of your patients. Do you have a lot of handicapped patients? How are you going to get them out of the clinic? Are we sheltering in place? Those kinds of things. Number 2 is the means to shelter in place. Let me just add here that shelter in place in a critical access hospital, which most of you are attached to as opposed to general hospitals, includes, for the hospital now, includes water, X amount of gallons, blankets, food. That does not apply to rural health clinics. Shelter in place for rural health clinics means keeping those patients safe because there's a chemical leak outside and you can't let them leave the building, or there's a tornado out there. What are you doing because you can't let them leave the building? That's really what it means. We're not talking about long-term, and you do not have to prepare for that in a rural health clinic. That's been a little bit of a misunderstanding. Patient staffs and volunteers, and you'll see that word volunteers. That comes up again in that you need to preempt this. You need to know who your volunteers are going to be. My first thought was the spouses of all those people that work in the clinic, but who knows where they work or live if something happens in your town. But you need to have identified volunteers that you can call on if you need a hand in your clinic, who will remain and who can come to the clinic, depending on the situation, of course, and all these depend on the situation. Number 3, a system of medical documentation that preserves your patient information. That's your files. Where is your backup? How is that secured? Protects confidentiality, obviously, of the patient information, secures and maintains the availability of records. Number 4, the use of volunteers, I mentioned in an emergency, including the process and role for integration of state and federally designated healthcare professionals to address surge needs during an emergency. So is the best thing in, let's say, in your policy you talk about this kind of a emergency, is the best thing to close the clinic and have the whole staff go to the hospital? That's what the community-based part of this is all about. The whole town comes together and puts this plan together. Fire, police, faith-based organizations, because they have room, they have a gym, schools, we can put patients there. Those kinds of things are what comes together with this kind of planning. The interpretive guidelines then for policies and procedures, the RHC must develop policies and procedures that align with the hazards which you've identified and the RHC's overall emergency preparedness program. The survey procedures review the written policies and procedures which address the RHC's emergency plan and verify the following. So this is your surveyor saying to you, okay, what are your policies and procedures? Were they based on a community-based risk assessment using an all hazards approach? And what is your communication plan, which is coming up? Verify your policies and procedures provide for the safe evacuation of patients from the RHC, including how it will provide a means to shelter in place. So if you are in a tornado area, then you must have a spot in there that you know is safe, that's not external walls, right, or windows. And who are the volunteers that are going to come? Who's going to remain in the clinic? Number 3, that your policy ensures the medical record documentation, preserves patient information, confidentiality, of course, etc. And number 4, includes the use of volunteers and other staffing strategies in its emergency plan. C, when surveying the RHC, verify that all exit signs are placed in appropriate locations to facilitate the safe evacuation. Ask to see documentation that verifies the policies and procedures have been reviewed and updated on an annual basis. I told you you're going to hear that a lot. It's in there 20 times. And so for that very reason, let's make sure these policies are signed and dated, or they're in one book, and their policies, and there's a signature page on the front that the entire staff has signed, that we've been trained on it, we learned it. A training log would be good in there as well, so that we know it's annual. So anytime somebody comes, they're never more than a year old. The communication plan. The RHC must develop and maintain an emergency preparedness communication plan that complies with federal, state, and local laws, and must be reviewed and updated at least annually. The communication plan must include all of the following. Now here, they're very specific at CMS that they're asking for the names and contact information for the following. So this will have names. This isn't a title. This is Dr. Smith or Mary Jones, the nurse, or Susie, the NP, whatever. The staff, entities providing services under arrangement, patients' physicians, other RHCs in the neighborhood or FQHCs that you can call on to join forces, and your volunteers. These are by name in the policy with contact information. The contact information for the following also is in your policy: your federal, your state, your tribal, regional, local emergency preparedness staff, and any other resources that you can come up with when you have this community-based meeting. Primary and alternate means for communicating with the following: your RHCs, others, your staff, and of course all these agencies. So the phones could very well be down, and that's what they want you to think about here. What happens if the phones are down? What's your alternate plan? Number 4, a means of providing information about the general condition and location of patients under the facility's care as permitted under 45 CFR 164. That's a different place to look. So you have patients that maybe are homebound. Maybe you go see them. Maybe they have to have special transportation. You know who they are. Let's get a list of those. Let's know who they are. So God forbid we need this kind of information. It's at your fingertips. And 5, a means of providing information about the RHC's needs and its ability to provide assistance to the authority having jurisdiction, typically called an incident command center or designee. How do you fit into the big picture? Very important part of your communication plan. The interpretive guidelines on this say the RHC must have a written plan that shows how how the RHC coordinates care with the RHC across healthcare providers and with state and local public health departments. The plan should include how the RHC interacts and coordinates with emergency management agencies and systems to protect the health and safety in the event of a disaster. So the surveyors are going to ask and verify that the RHC has a written communication plan. That's different than your policies. This is your communication plan. You're going to be asked to show it. They're going to ask to see evidence that the plan has been reviewed on an annual basis or updated as needed. And that would be very specific to the staff, because people leave, they go on maternity leave, or they move on, or there's somebody new hired. So that would need to be added. So that would be as needed. Verify that all required contacts are included in the communication plan by asking to see this list of contacts with their contact information. I would suspect this is going to be cell phones. I don't know how else you're going to do that other than cell phones. Number 4, verify the communication plan includes primary and alternate means for communicating with the staff, the federal, state, tribal, local emergency department, and management agencies by reviewing the communication plan. Now, they give other ways here besides the cell phones: pagers, walkie-talkies, ham radios. I have one clinic already going to invest in ham radio. The law is not telling you that you have to do that. What they're telling you is you have to have a plan other than your telephone in your clinic. Number 5, ask to see communications equipment or communication systems listed in the plan. So if you say you're going to use walkie-talkies or whatever, you're going to show that you have those. If you're going to say you use cell phones, you're going to show the list of those names and phone numbers, and you're going to have that handy, and everybody's going to have a cell phone on them, which is something to think about. Number 6, verify that the RHC has developed policies and procedures that address the means the RHC will use to release patient information, to include the general condition and location of patients by reviewing the communication plan. So you might have several people down in your clinic. How are you going to communicate that to the command center? Verify your communication plan includes a means of providing information about the RHC's needs and its ability to provide assistance. So that goes both ways. What are your needs, and what can you offer to the whole big incident? To the authority having jurisdiction, the incident command center designate by reviewing the communication plan. Training and testing. The RHC must develop and maintain an emergency preparedness training and testing program that is based on their emergency plan. We won't read that again. And guess what? The training and testing must be reviewed and updating annually. So you're going to have training annually, as you do now for your emergency plan, but it's much simplified. But you're going to have this at least once a year. The training program must do all the following. Initial training in emergency preparedness policies and procedures to all new and existing staff. So catch that. If you've got this all in place November 15th, you're good to go, and you hire somebody in January, you're going to document that you've trained them on your emergency preparedness plan. And that would be in this binder, in the log, however you do your training logs. To all new and existing staff, individuals providing services under arrangements, the volunteers, consistent with their expected roles. So provide emergency preparedness training at least annually, maintain documentation of that training, and demonstrate staff knowledge of emergency procedures. And that's where you'll hear in the surveyor guidelines what they're going to do. The testing. The RHC must conduct exercises to test the emergency plan at least annually. The RHC must do the following. Participate in a full-scale exercise that is community-based, or when a community-based exercise is not accessible, an individual facility-based. If the RHC experiences an actual natural or man-made emergency, either one, that requires activation of the emergency plan, the RHC is exempt from engaging in a community-based or individual facility-based full-scale exercise for 1 year following the onset of the actual event. So God forbid something does happen and in September, and you've had to use this plan, you've got a full year till you have to have another plan, another exercise, because you lived it. And that's the best, well, it's a good way to learn, but not the one we want. Further on testing, conduct an additional exercise that may include, but is not limited to, a second full-scale exercise that is community-based or individually facility-based. A tabletop exercise that includes a group discussion led by a facilitator using a narrated, clinically relevant emergency scenario, and a set of problem statements, directed messages, or prepared questions designed to challenge an emergency plan. So letter B is a whopper. You will find, at the end, I'm going to give you some sources that you can go to so you can find these kinds of things and don't have to recreate the wheel here. There are FEMA and other people that, ask for Tracy, which is a government contractor, wonderful website for you, that you're going to find a lot of these tools so that you don't have to think this up on your own and have your tabletop exercise in your clinic with your staff to review some things and challenge your own plan. Further on testing, analyze the RHC's response to and maintain documentation of all its drills, exercises, emergency events, and revise the plan as needed. So you're evaluating and constantly revising this as you grow and learn in this subject. The interpretive guidelines say an emergency preparedness training and testing program must be documented and reviewed and updated at least on an annual basis. The training and testing program must reflect the risks identified in the clinic's risk assessment and be included in the emergency plan. So they're going to look to see if you talked about train wreck in your town with chemicals being released, and then you didn't have a plan for that, you're going to be dinged for that, okay? So that's how the evaluation will go. So whatever you put in as your risks, your all-hazard approach, you need to have a plan for it. The surveyor procedures then tell them to verify that you have an emergency preparedness training and testing program, verify the program has been reviewed and updated on an annual basis, and ask for copies of your initial emergency preparedness training and annual emergency preparedness training offerings. So how are you training your staff? What do the tests look like? What were the results of those that took it? 4, interview various staff and ask questions regarding the RHC's initial and annual training course to verify staff knowledge of emergency procedures. This should have already been happening for you for fire drills. We should be able to walk into any clinic and ask any person working there, what is your fire procedure? And they should be able to tell us. So you're just expanding that now to all the rest of it, but you should be used to that sort of a procedure. Number 5, review a sample of staff training files to verify that the staff has received initial and annual emergency preparedness training. So this tells you you're going to document it and they're going to sign a piece of paper that says, I received training today on July 20th for emergency preparedness in our clinic. Or pardon me, or there's going to be a log with had all the names on it, and then I'd even have their signatures there because they're specific about the training file. On the testing side, the interpretive guidelines say the RHCs must, on an annual basis, conduct exercises to test the plan. Specifically, RHCs are required to conduct a tabletop exercise and participate in a full-scale community-based exercise, or conduct an individual facility exercise if the community-based exercise is not available. For the purpose of this requirement, a full-scale exercise is defined and accepted as any operations-based exercise that assesses a facility's functional capabilities by simulating a response to an emergency that would impact the facility's operations and their given community. RHCs are expected to contact their local and state emergency agencies and healthcare coalitions where appropriate to determine if an opportunity exists and determine if their participation would fulfill this requirement. In doing so, they are expected to document the date, the personnel, and the agency or healthcare coalition that they contacted. So a lot of pieces to this. You're going to, if you're a provider-based clinic, you're going to get involved in the hospital-based plan, and you're going to document who went to that meeting, who went to the exercise day, signed, dated, all of it, so that we know that the clinic participated. Now, not every employee in the clinic, when it's provider-based, is probably going to go to that meeting. Maybe the exercise, but not the meeting. So that behooves you to come back from that meeting and reproduce it for your own clinic staff and document it. RHCs that are not able to identify a full-scale community-based exercise, and truly this is, a lot of rural health clinics are independent, they're very rural, of course, and they're sitting out there by themselves. And maybe there's a little town, but maybe they just couldn't, you just couldn't pull it together. So here's what you do. Can instead fulfill this part of the requirement by either conducting an individual facility-based exercise, documenting an emergency that required them to fully activate their emergency plan, or by conducting a smaller community-based exercise with other nearby facilities. So perhaps you're the only medical office in town, but you've got a church, you've probably got a fire company, you may even have an ambulance there. Those people can come to, the chief of police, they can come together and have a meeting, and you will well document the discussions and how you're going to prepare for an emergency in your town. The surveyor procedures for the communication, or the testing, excuse me, ask to see documentation of the annual tabletop and full-scale exercise, which may include, but is not limited to, the exercise plan, the AAR, which is the after-action report, and any additional documentation used by the RHC to support the exercise. 2, ask to see the documentation of the RHC's efforts to identify a full-scale community-based exercise if they did not participate in one, i.e. date, personnel, agencies contacted, the reasons for the inability to participate in a community-based exercise. So you're going to have a whole write-up, if you can't do this, of who you contacted, what they said, what the result of that whole conversation was in a file. You must request documentation of the RHC's analysis and response and how the facility updated its emergency program based on this analysis. So you're going to, if you're going to do a community-based exercise, you're going to analyze it, evaluate it, and see what you need to change in your plan. Obviously, that was the whole reason to do the thing. If an RHC is part of a healthcare system consisting of multiple separately certified healthcare facilities, so your hospital is certified, each individual RHC has a separate certification, okay? That's what we're talking about here, that elects to have a unified and integrated emergency preparedness program. The RHC may choose to participate in the healthcare system's coordinated emergency preparedness program. I would be sure you would. If elected, the unified and integrated emergency preparedness program must do all the following. So what we're saying here is you're going to participate in your hospital owner, their emergency preparedness program, which again, I would expect you would, but there's real specific guidelines. You still need to do some things. You need to demonstrate that each separately certified facility, that's each clinic within the system, actively participated in the development of the unified and integrated emergency preparedness program. They didn't just send you the minutes from the meeting that you didn't attend from your clinic. You participated. Be developed and maintained in a manner that takes into account each separately certified facility's unique circumstances, your patient population, the services you offered, your location. You are unique. You have a unique billing number to you, and you have to participate based on what's different for you than is different for the hospital. And demonstrate that each separately certified facility is capable of actively using the unified and integrated emergency preparedness program and is in compliance with the program. So you would have to bring the hospital plan back to your clinic and have it reviewed by your staff to see, okay, do we understand it? Can we activate this? Can we be a part of this and integrate into the hospital's program? Number 4, included include a unified and integrated emergency plan that meets the requirements. The paragraphs are from the original law. The unified and integrated emergency plan must also be based on and include all the following: a documented community-based risk assessment, utilizing an all-hazards approach, a documented individual facility-based risk assessment for each separately certified facility within the health system using an all-hazards approach. Include integrated policies and procedures that meet the requirements set forth in paragraph B of this section, a coordinated communication plan, training, and testing program that meet the requirements of paragraph C and D, respectively. So the interpretive guidelines say the healthcare system that includes multiple facilities that are separately certified as a Medicare participating provider or supplier have the option of developing a unified and integrated emergency preparedness program that includes all the facilities within the healthcare system, instead of each facility developing a separate emergency preparedness program. We get that. We understand that quite perfectly. The surveyor is going to verify whether or not the facility has opted to be part of the healthcare system's unified integrated emergency preparedness. Verify that they are by asking to see documentation of its inclusion in the program. So the hospital program is going to have Dr. Moore's clinic named in that policy, if that's the name of the clinic. They're going to be named in the plan and what their role is in the coordination of efforts. Ask to see documentation that verifies the facility within the system was actively involved in the development of the Unified Emergency Preparedness Program. Ask to see documentation that verifies the facility was actively involved in the annual reviews of the program. And we won't hit that for another year. Now we're just beginning, but at least in the process of the program's requirements and any program updates. Ask to see a copy of the entire integrated and unified emergency preparedness program and all required components: emergency plan, policy procedures, communication, training, and testing. And then ask facility leadership to describe how the unified and integrated emergency preparedness program is updated based on changes within the healthcare system, such as when facilities enter or leave the system. Obviously, if you're an independent and you were just purchased by a hospital, you'd be added into one. Perhaps one goes away and it would be out of that part. So doctors' offices do not have to do this. So if you became a physician's office and left the system, you wouldn't be a part of that. And it would be reflected in the plan. Some specifics. Outpatient providers are not required to have policies and procedures for the provision of assistance needs. I put that in because we're getting that question a lot. You do not have to provide food, water, blankets for an extended period of time like you do at a hospital. The RHCs must still have a policy and procedure detailing how refrigerated medications will be handled during and after disaster. So that's going to be part of this plan. It was not called out. It didn't go away because it's the safety of our medications. The RHC procedure may be to evacuate staff, patients, when safe to do so, or it may be to close and secure the clinic and notify the staff patients that the clinic is closed till further notice. We had a major flood last year in Louisiana, and one clinic was totally destroyed. And they actually were seeing patients 2 days later in the parking lot, a drive-through situation where that nurse practitioner was just amazing. She's really quite a hero. She would walk to each car and see each patient who was driven to her. And then within a week or 10 days, somebody donated a trailer, put it in the parking lot because the building had to be gutted. And they kept seeing their patients. So it's just really a story. I can't answer the question if you were going to ask it, did she have that plan before? I don't know. But they certainly will have one by November 15th. CMS estimates that for an independent clinic, it's going to cost an average of $6,000 per clinic to implement these emergency preparedness rules. I seriously appreciate that this is a burden for you guys, and I was a bit surprised at the burden for independents particularly, but there it is. That's their number. Independent RHCs will be impacted more adversely due to their limited labor, obviously, and financial resources. That's a no-brainer statement. Okay, so providers and suppliers should refer to the resources on the CMS website. There's a lot of resources there. I'm giving you the link here to develop your emergency preparedness plan. Like I say, do not have to reinvent the wheel. Take all the resources and refine them to your clinic. And there's the website for Survey and Cert for emergency preparedness. And they're listing some there of a pandemic. Now, I didn't even mention that. A real Zika virus or something that's spreading like wildfire to your community. What's your plan? The hurricanes, tornadoes, fires, earthquakes, power outages, chemical spills, nuclear, biological, terrorist attack, and of course the big et cetera. More resources at cms.gov. There are several pages of FAQs, frequently asked questions, on the CMS website, and there's a link to that. So if you have a question, it very well may be answered right there. Now, I mentioned Asper Tracy. They have amazing resources on their website. This is a government contractor who that's their thing, is healthcare emergency preparedness. They've been in business a long time, but now they're coming into play for us. I was not even aware of this until this rule came out last year. FEMA also has lots of resources on their website. They're the ones that got caught in Katrina that we're aware of course. So you see they have drills, they have what is a tabletop exercise. So you can get all these things to help you to put your plan together in 4 months. Many places have active shooting. I would recommend, I've seen at least 3 good ones on YouTube so that you can show that at a training meeting at your clinic and then document who saw it and what was discussed. What's your plan? The biggest mistake, and I'll just share it here because it's on my mind, is that we all huddle in one corner when there's an active shooter. And that just struck me. It's very hard video to watch. You do not want your children to watch it with you, but this fellow just takes them all out in the corner. It's a police exercise. There's not real bullets. But the fact is, it's frightening to see that. They huddled together and they were an easy mark. So we want to spread out. That's just a little side message there. So you can find, if you start, probably your own universities in Indiana have emergency preparedness training within their resources. NRHA has resources. NOSOR has resources. HRSA and RHI Hub. You can get help in a lot of different places. I urge you to use those to write this program. Now, so scoring. So in the event facilities are non-compliant, it's the same as any other deficiency. The general enforcement procedures will occur as is currently in place for anything else. So what does that mean? That means if we go back to the beginning and we see policies and procedures, tabletop exercise, all the 4 parts, training and testing. If you had none of that, that would be a condition level deficiency, and you're on a 45-day track to lose your billing number. So if they walk in the door and you have none of that. If you're missing a policy, but you had a tabletop exercise, your staff's informed, you've got all your list of your contacts, you're good, that's a standard level deficiency that you can fix within 60 days. So you've got to get going. We do not want to have anybody out there that doesn't have any of this done, because that's condition level and that puts you in a bad place. And I will say thank you with that. Allie, if you have any other comments, I am complete for the time being, unless there's some questions.
No, Kate, we just really appreciate you being here today and taking the time out to talk about this with us, especially with the deadline for implementation coming up. There's clearly a lot involved to do this correctly. So I think you've provided a lot of good information here for all of our RHC and other kinds of clinic members. So we just really appreciate your time today. And if anybody has any questions, you can see there Kate has shared her contact information. My contact information is aorwig@indianarha.org. So it's aorwig@indianarha.org. You can always contact me if there's anything I can do for you. But we just really appreciate everyone's time and hope that everyone has a good day.